This is these are insights on advances in kidney cancer ablation. Basically, how it is positioned nowadays, and the perspectives and the meaning of that. So we will discuss a little about how it can compare to a partial nephrectomy. I'm Leonardo Reis from Brazil, professor of urology at Pontifical Catholic University of Campinas and State University of Campinas. So I have no conflict of interest for this talk. Those are my fundings are mainly government from government. Basically, we will go through four steps. Like we will start talking about small renal masses, the definition, where we are, and the importance of core biopsy for those the ablation, and then I will finish with four challenging cases that will illustrate the concept we are discussing here. So small renal masses, we know very well, below 3 to 4 centimeters, T1A stage. They have basically low renal cell carcinoma specific mortality. That's it's an important point. In that context, we have significant competing cause mortality. Basically, surgery is the standard of care in that scenario. Ablation is reserved for elderly or comorbid patients. Um, Randomized clinical trials failed to meet accrual targets, so we are lack of high-level evidence in the field. When we talk about core biopsy, that is super important to navigate this setting. Sensitivity is super high, as you see, specificity also over 95%. Positive predictive value is 99%. It's very it's reliable for subtype and grade of tumor also. You can repeat biopsy, and this can improve the specificity and sensitivity also. It's safe. You can see that the minor and very uncommon adverse effects, and basically no tumor seeding. So it's a safe and precise procedure that will support ablation. So when we look at the kidney cancer ablation, there are potential for lower morbidity, lower time for the procedure, lower narcotic requirements, lower hospital stay, transfusion, and even conversion to radical nephrectomy. We see quicker recovery, equivalent oncological outcome, though with higher local recurrence, though also we can repeat ablation. They can be rescued with partial or radical nephrectomy. So patient selection is key, though no trials, randomized trials, and no definitive conclusion based on the best evidence are available. So then patient selection is key and lots of potential. Usually percutaneous is the best way to go. Energy doesn't matter a lot. Any energy source can do the job. Indications usually below 3 centimeters in elderly comorbid patients, unfit for surgery mainly. Those in risk of chronic kidney disease, high risk of complete loss of renal function like solitary kidney, bilateral tumors, predisposition to multiple tumors, recurrence after surgery. Usually we avoid the hilum for obvious reasons. So this is the main slide here. This is the dilemma. The point is this is the timeline, and as time goes, we age, comorbidities happen, and values change. So when you look at the diagnosis and the treatment, it come with adverse effects, and also those patients have concurrent death causes. The point is how to decrease adverse effects and predict concurrent death of causes. And then the treatment can be anytime before the red point here that is the expected benefit. This between the yellow and the red, there is the window of opportunity, window of treatment. So there is a wide window of opportunity, and treatment, the intensification and super acute surveillance with ablation is a there are high or opportunities, or lots of opportunities there. So this is an important study showing that though trials failed to meet the accrual targets, there are strategies with embedded randomized control trials to uh, to reach the goal. So you can see that there are steps: screening, enrollment, then allocation, and follow up at 6 months. In this case, we end with more than 20 cases in each arm, and it was proved that it's feasible. So there is hope for the near future that we will have better evidence to support decision. And you see data here, not powered to detect differences in outcomes. This is 6 months follow-up, but you can see pretty reasonable results, and you see that mainly that is feasible, and there is hope for new evidence and to support the practice. So the cases we want to share are like this one is the first case, a 63-year-old woman with a solitary kidney with a decreased glomerular function. So you see the lesion right there, and then it was needed pneumo dissection to put the ureter apart. So those are like strategies we can use to keep ablation a good indication for special cases. And you can see like before and after, and the glomerular function preserved. The lesion was disappeared. So a good example of application. The case two is another female 58-year-old with VHL, and you see the follow-up started with active surveillance in 2017, small lesions that got bigger, so didn't want to go through to partial nephrectomy, started active surveillance, wanted something more like surveillance. So ablation was a good option for this case. So here you can see after ablation how what happened, and also good results. Here is showing the both lesions and what we got after the ablation. So the third case is another female woman, 7-year-old with partial nephrectomy under follow-up, and you see in 24 months recurrence here. So this is an example that we can also treat recurrence after partial nephrectomy. This is an uncommon indication, but it happens. So we did here ablation for, this is the lesion, what happened after partial nephrectomy, 24 months. And then she got an ablation, and you can see before and after, so control of the lesion. And the very last case is another case with multiple bilateral lesions in this case. So this is an example where we can use multiple or combined strategies: partial nephrectomy for some lesions here in red, and ablation for other lesions. So it's also an opportunity to combine approach: partial nephrectomy for some lesions and ablation for other lesions. So the conclusions are cure necessary. So it's super important to avoid over treatment and adverse effects. In kidney, they are not super important, but still present. So the most important thing is to cure when it's necessary, not just because you have a lesion, and if that lesion won't impact the quality of life or length of life, maybe we don't need to target that some lesions. So in other words, it's necessary to evaluate new tools. This is, I thank my friend Ketan Badani that made such conclusions for his talk at partial nephrectomy, but it looks like it's much more adequate for ablation. So to identify and close gaps in the current practice and improve patient outcomes and personalized care. So patient selection is key. Thank you so much. This is our team. I should mention Dr. Tiago Penaquin, that is our radiologist and radiation interventionist that work on those cases with us. Thank you so much.